Our next speaker is Dr. Joe Markenson, who's a clinical professor at Hospital for Special Surgery and Weill Cornell Medical School. He's also a professor at Sloan Kettering. And here's his CV, where he was fellow at the Hospital for Special Surgery. And he's going to talk today about the rheumatic manifestations of endocrine disease. Joe.
Good evening. Well, I'm standing between you and lunch, and I'm going to painfully drag you through some of your medical school thoughts about endocrinology. Let's see. I'll remember how to do this. So rheumatic manifestations are often the initial presentation of generally some systemic disease. And they can be very important. We teach our residents when the patient comes in with a certain particular rheumatic disease, the first thing you want to do is not assume that this is gout or RA or OA, but think of all the things in internal medicine this could be. So each disorder may have its own arthritic complaints, which can present as a definite rheumatic disease, such as pseudogout, or as a rheumatic symptom, such as diffuse arthralgia, or the nice consult of the lady who comes in and says, why are you here? Well, my internist drew an ANA and I have a positive ANA, figure out why I have it. So those are the presentations we usually get. Let's look a little bit at hypothyroidism to begin with. Most common cause is acute autoimmunity, Hashimoto's, and central hypothyroidism can also occur, Sheehan syndrome, postpartum thyroiditis. There are drug-induced episodes of hypothyroid, such as lithium, amiodarone, iodine deficiency, and the last, of course, iatrogenic. What kind of complaints do these patients have? Well, they can have symmetrical arthropathy that affects with stiffness of their hands, knees, or joints. They can have palpitations. When you palpate, the joints feel gelatinous. Aspiration of fluids are generally non-inflammatory, viscous. Occasionally, they have deposition of CPPD crystals, and obviously the association of CPPD and hypothyroidism was first described in about 12 myxodematous patients back in 1975. What other things can you get along with, let me go back here, CPPD? All of these are listed for you. These are entities in which you can achieve or see CPPD disease. What do you see in hypothyroidism? You can see some prominent osteophytes at the MCPs and actually appositions of them. And you can also see this thin, nice line of calcification in the knee joint, which makes that diagnosis for you. What do they look like sometimes? Well, you can have swelling of second and third MCPs in a patient with CPPD. This is generally the second MCP is considered to be the one in which you see mostly in hypothyroidism or chondrocalcinosis. You can have a myopathy with thyroid disease. It can present as pain, cramps, stiffness, easy fatigability, and weakness in about 80% of the patients who have it. Your exam shows you some hypertrophy, some proximal muscle weakness. There are delayed relaxations of these deep tendon reflexes, which one sees mostly in hypothyroidism. And you get a sustained focal contraction of skeletal muscle when you strike them with a reflex hammer. There are some congenital forms which are listed here for you, which look like pseudo-hypertrophy of muscle. You can see this syndrome in infants where cretinism is seen. And they generally will have elevated muscle enzymes, myoglobin, but the EMGs are often normal. Biopsies look like steroid myopathy with type 2 fiber atrophy, and abnormalities will correct when you replace thyroid. Graves' disease, another thing one sees in hyperthyroidism, usually with pretibial myxedema, where you get these little nodules that look anywhere like bluish or grayish episodes on the anterior tibia, if you will. You can get adhesive capsulitis, muscle loss, weight loss, and osteopenia. You can even get clubbing and thyroid acropathy, which is not showing up well in my picture here, and it can be associated with periosteitis in the around the MCPs. What's